then to the ventricular myocardium. هذا كله راح يعطينا ال summation of the action potential of the heart muscle، راح يعطينا ال PQRS T wave complex اللي كلكم تعرفوها. And it's important نعرف ال definitions of ال ECG findings اللي احنا لما نطلع على ال ECG لازم نعرف انه شو يعني large square، شو يعني small squares، كم هذا بالملي سكندز او بالسكندز. لازم نعرف شو يعني P wave، PR interval اللي هي beginning of P to the beginning of the QRS complex. لازم نعرف ال QT interval، نعرف ال ST segment، ونعرف نعمل interpretation to each one of these. Okay. So البيدياتريك اريثمياز والادلت اريثمياز هل هم نفس الشيء ولا لا؟ هم بيختلفوا شوي عن بعض، بس يعني نفس البرنسبل بالنسبه للاريثمياز، ونفس الاسماء مرات مستخدمه بالبيدياتريكس والادلتس، يعني ما في اشياء كثير مختلفه except for a few things. يعني في عندنا peculiar pediatric arrhythmias different شوي عن الادلتس. واي يعني الاي سي جي كمان بالبيدياتريك بيختلف عن الادلت زي كل شيء. يعني بالبيدياتريك اي سي جي في changes that happen with age. في dominance of the ventricle ممكن يتغير من ال right ventricular dominance لل left ventricular dominance خلال فترة قصيرة اللي هي after birth. So once the baby is born the right ventricle is more dominant، بعدين بصير ال left ventricle dominant within a few months. So it changes with age. مش بس الدومينانس، كمان الانترفالز changes with age. مثلا ال PR interval is shortest at the newborn، ال QRS is narrowest at the newborn period, etc. وعشان هيك في normal values for each of these. فلما نيجي نطلع على ال ECG it's not a bad idea for children انه نطلع دائما على normal values for that specific age group عشان نعرف نعمل interpretation in the correct way. الانديكيشن تو جيت ان اي سي جي برضه بالبيدياتريك شوي بتختلف على الادلتس. most adults will get an ECG because of chest pain or because of مثلا palpitation. in children في كمان other indications to get an ECG. Also as in adults we have to consider the clinical picture when we interpret the ECG. يعني لازم نعرف ليش هذا ال ECG انعمل عشان to focus على a few things بال ECG to interpret the ECG. So we start reading the ECG by the basic things. We read the rate, determine the rhythm, if it's regular or not, the P wave, the PR interval, then the QRS duration and axis, and if there is any abnormality in the shape of the QRS, and the ST segment, is it elevated or depressed, T wave, morphology, and U wave, and the QT interval. And you have to calculate the QT interval in every patient. طبعا الريت كلكم تعرفوا كيف تحسبوا الريت. والريت لما نحكي ريت we determine the QRS rate مش the P wave rate. Sometimes we calculate the P wave rate عشان نعرف إذا في dissociation أو في difference بين ال atrial rate and ventricular rate. ال PR interval we measure it in seconds or milliseconds and then determine based on the age group إذا normal ولا prolonged ولا shortened. ال RR interval is determined in second and then you divide 60 by the RR interval بعطيك الريت، أو 300 على ال large squares أو 1500 على small squares between the RR. هاي الطريقة بنعرف فيها ال heart rate. الرhythm has to be regular عشان هاي الإيكويشن تكون صحيحة، لأنه إذا كانت irregular rhythm ما حتكون صحيحة. If the rhythm is irregular لازم نحسب ال heart rate على مدى أطول، على مثلا 1 minute of monitoring. Rhythm, all what you need to do is to tell me إنه is it a regular rhythm ولا not regular rhythm, and then you determine if it's sinus ولا لا. Then proceed with the ECG reading. نطلع على P wave. في عنا ال shape of the P wave will determine where it came from. فزي ما بنعمل QRS axis نعمل كمان P wave axis. فإذا ال P wave positive in 1 and AVF, most of the time you can say no, this is sinus. If it's negative in lead 1, معناته it's coming from the left side, so it's not from the sinus node. So it's important to know the shape and the positivity of the P wave زي ال QRS. Morphology of the P wave في two things that we like to know. إنه في عنا P mitral و P pulmonal, and this will indicate the right atrium or or left atrial enlargement, يعني muscular enlargement of the atria. Then you look at the PR interval. You determine if it's normal in duration or prolonged or different from one beat to the other. يعني في dissociation ولا ما في dissociation. وفي طبعا short PR interval اللي بتكون part من الولف باركنسون وايت syndrome, specific syndrome بالtachyarrhythmias. So again, as we said, usually in children, بتكون PR interval is shorter, and then it gets longer as the child grows. For example, if you have a long PR interval and that's it in the whole ECG, you say it's a first degree AV block, and usually it's a benign condition that does not lead to any problem. If the PR interval is not normal, it's يعني في عنا progressive prolongation of the PR interval. تعرفوا هذه بتصير بحالات ال AV block, خصوصا الموبتس 1 أو الونكي باك phenomena. So في عنا prolongation of the PR interval until the next P wave is not followed by the QRS. فبتصير في عنا drop in the beat. فبنسميها second degree AV block موبتس 1. ممكن تكون variable PR interval, فهذه بدنا نفكر بالديسوسيشن. يعني انه في عنا P wave rate different from the QRS rate. هذه بتصير بالcomplete AV block. في عنا طبعا short PR interval بتصير بالولف باركنسون وايت. فهي example of an abnormal PR interval. QRS you have to look at the QRS axis. برضه نفس الشيء بتطلع على lead 1 و AVF, اسهل اثنين عشان نعرف منهم الاكسس. So if it's positive in both of them, it means the impulse is going from the right upper corner to the left lower corner, so it's going with the axis of the heart. So this is a normal QRS axis. Of course, we have right axis in neonates, then the right ventricle is dominant, and then this axis goes to the normal within a few months of life. فبصير في عندنا normal axis اللي هو between -10 and 110 degrees. Duration of the QRS is also important. Usually QRS is a narrow complex, but if it's wide, then you have to think of a conduction delay somewhere, either bundle branch block or ventricular origin of the impulse. The morphology also changes with age. بيكون في عنا prominent right ventricular morphology in the neonates, بعدين بصير عنا left ventricular prominence in the later age groups. برضه لما تطلعوا على الاي سي جي، هذا بس هيك ريفرشمنت اوف ذا اي سي جيز، يعني لسه ما دخلنا بالاريثمياز. لما نطلع على الاي سي جي في ديفينيشنز معينه، في عندنا شيء اسمه inferior leads، في عندنا lateral leads، في عندنا septal leads etc. Inferior leads anything pointing down, so obviously AVF is an inferior lead, and also lead 2 and lead 3 are inferior leads. في عندنا lateral leads اللي هي ال V5 وال V6 indicates the left ventricle mainly. وفي عندنا rightward leads اللي هي V1 is a rightward lead. مرات بنحط ال V3 على ال right side، بصير في عندنا V3 arc for example is represent the right ventricle. وسبتال leads بتعرفوها. Q waves, the importance of the Q waves بالادلتس، بتعرف ال Q waves بتطلعوا على الاسكيميا، chronic ischemic changes بيعمل Q wave. بس بالchildren يعني we rarely see ischemic changes بالchildren، بس if it's more than 3 millimeters then it's probably significant Q wave. ممكن انه نشوفها بحالات الانومالي بالكوروناري arteries، يعني congenital anomaly بالكوروناري artery مرات ببين عندنا prominent Q waves in on ECG. وبنشوفها كمان بحالات الventricular hypertrophy. Okay. Another thing that we look at for QRS is to determine the ventricular hypertrophy. في عندنا right ventricular hypertrophy و left ventricular hypertrophy. في different criteria. The only one that I need you to know اللي هي the first criteria اللي هي tall R wave in V1. It indicates usually right ventricular hypertrophy. و tall R wave in V6 indicates left ventricular hypertrophy. اللي هي نفس definition of the leads. So V1 indicates the right ventricle. فإذا ال R wave is very tall, it's RVH. It's the if the R wave is very tall in V6, then it indicates left ventricular hypertrophy. في طبعا other criteria, those are not يعني required from you. ST segment بنطلع دائما في elevation or depression. Elevation بالأطفال مهم كتير نعرف إنه pericarditis leads to ST elevation, usually in more than one leads. بس برضه ممكن تصير بحالات الإسكيميا which is not common. Depression of the ST segment is also an ischemic change. Okay. T wave بالأطفال بتختلف عن الكبار، إنه in V1 T wave is usually inverted يعني negative except in the neonatal period بتكون upright. In adults most adults بتكون التي ويف خلاص صارت upright in V1. اوكي. مرات بنفرجيكم ECG بيكون في ال amplitude of the T wave is abnormal يعني انه very tall amplitude of the T wave. This is important في حالات الهايبركاليميا. اوكي U wave is not important. الهايبركاليميا بتصير والكيو تي انترفال لازم تكونوا عارفين الكيو تي انترفال ايكويشن اللي هي measured QT divided by the square root of the R to R interval and that will give you a number. هذا النمبر لازم يكون أقل من 450 to consider this as a normal QT interval. Prolonged QT interval is a killer disease. You have to detect it عشان تتأكد إنه there is no sudden death risk. Okay. So as we said, indication to do an ECG in a child. مثلا a child comes in with loss of consciousness. لازم نعمل ECG. A child with palpitation, obviously you have to do an ECG. إذا عندنا child with suspected congenital heart disease, it's advised إنه نعمل ECG لأنه بيساعدنا بالchamber sizes, بالchamber hypertrophy. If the child has an incidental finding of a rapid heart rate or abnormal heart rate, you do an ECG. And if the child has chest pain, you have to do an ECG. Okay, so those are some of the indications why do we do ECGs in children. And we will talk about the rhythm anomalies that we might see in children now. So, which is obviously diagnosed by doing an ECG. But in summary, the rhythm anomalies that you might face in children are either bradycardia or tachycardia or an irregular rhythm that does not belong to either one. Okay, so bradycardia, so any child who has slower heart rate will be either sinus bradycardia or AV block or sinus node dysfunction. Those are the three things that will result in bradycardia in children or even adults. So it's either the sinus node is just slow because of physiologic reason, or the sinus node is diseased, so it doesn't give you any automaticity, so it's abnormal sinus node, or the sinus node works, but the AV node does not listen to it, and it does not conduct, so that will result in bradycardia. So those are the three mechanisms. So sinus bradycardia, usually it's not a cardiac disease. It's either because of a pathology not related to the heart, or due to a stimulus, a medication, for example, or due to a physiology like athletic heart, for example, they will be slow, etc. So usually it's not a cardiac disease. Sinus node dysfunction is a cardiac disease, and usually the sinus node in this disease is not able to produce the automatic rhythm, the automatic appropriate physiologic rhythm. So we call it sinus node dysfunction. It can present with severe bradycardia or absent P waves, totally absent P wave, or ectopic foci from the atrium because the sinus node is just dead. And this one results in bradycardia, but usually it's rare in children, but it can happen particularly after cardiac surgery around the SA node area. So if you have a patient who had cardiac surgery and now he presents, a few weeks later with bradycardia, do an ECG, look for the P waves. If the P wave is not present, then maybe the sinus node got damaged during surgery. It happens in adults because of MI, for example. If the artery to the sinus node is damaged or occluded, then some patients will get sinus node dysfunction. And the third cause of slow heart rate in children is heart block. So heart block is the sinus node works, but the AV node does not listen to it. There is a block at the AV node level. So if there is a block, and it's a significant block, like second degree or third degree, then not all the P waves will be conducted. So you will get bradycardia, or the QRS rate is slow. First degree AV block will not cause bradycardia because there is conduction after each P wave. So the rate is determined by the P wave. So only second degree AV block or third degree AV block will result in bradyarrhythmias. So this is an example of atrioventricular block where you have a lot of P waves. This is a P wave, and this is a P wave, and this is a P wave, P wave. So the rate of the P wave is normal for that child, which is a 3-year-old, but the rate of the QRS is much slower. It's about 60. So there is complete dissociation between the P wave rate and the QRS rate. This is atrioventricular block. So the sinus node works well, but the AV node is not working. If you get a patient who has syncopal episodes, as we said, you have to do an ECG. So this is an example of an 11-year-old who had syncopal episodes. We did the ECG and we found only sinus bradycardia. So the heart rate is very slow and it's sinus. There are P waves before every QRS. But one thing that you have to pay attention to in this ECG when you continue reading is that the T wave is actually very broad and wide. So if you calculate the QT interval, see that the T wave actually starts very late after the QRS. So this is prolonged QT syndrome. So long QT syndrome is also diagnosed in patients who have sinus bradycardia, and it's really a very bad disease. You have to pick it up to prevent sudden death in those children. So the QT here is 580, and which is very long. Okay, so those are the bradycardia. It's very simple. If you just go along the algorithm, ask yourself, is it sinus or not? Are the P waves present or not? If it's sinus bradycardia, look for the non-cardiac causes of the sinus bradycardia, but don't forget the QT interval prolongation. Now we come to irregular rhythm. Irregular rhythm can be either sinus arrhythmia, which is benign. It just happens because of the breathing in and breathing out. The heart rate will comply and get faster or get slower. So that's a normal finding. You might get irregular rhythm in patients with heart block, but that will be also bradycardia. Okay? And not all degrees of heart block will result in irregular rhythm. Only a certain degrees of heart block, like 3-to-1 block, you will get irregular rhythm. It's regularly irregular. But 2-to-1 block, it will be regular. Complete heart block will be regular. So some second-degree heart block will give you a regular rhythm. The others will not. Atrial fibrillation will give you a regular rhythm, but it's from the tachyarrhythmias. So it's not from just the heart rate will be high in those patients. And also premature ventricular contractions will give you some irregular or skip beats. And you have PACs and PVCs. So this is an example of sinus arrhythmia. So if you look at this rhythm strip, so this is slower, about 60 per second per minute, and this is about 100 per minute, and then goes back to 60, etc. But every single QRS is preceded by a P wave, and the P wave morphology is similar. So this is the same as this one, as this one, as this one. So all P waves are similar. The PR interval is fixed, but the rate changes. So you can imagine that this is because of inspiration and then expiration, then inspiration, expiration. So that's a normal finding in a child, and it's actually reassuring that his heart is good. So if we look at this ECG, this is also a irregular rhythm, but if you look at this one, you will find that there are some bizarre shaped QRSs every now and then. So this is regular, and then you get wide complex QRS without a P wave preceding it. Again, back to sinus, and then wide complex. So those are premature ventricular contractions. Okay. So the last topic is the tachyarrhythmia, which is the major topic in children. Tachyarrhythmia means the heart rate is faster than your expected physiological rate. Okay. So, and also we have 3 causes of tachyarrhythmias. So any child with tachycardia, you will get either one of 3 diagnoses. What are those? Either sinus tachycardia, just like the bradycardia, either sinus bradycardia or sinus node dysfunction or AV block. Here you have 3 causes. Either sinus tachycardia, which is usually non-cardiac. It can be cardiac in origin, but usually it's non-cardiac. And maybe cardiac if there is heart failure, but it's really compensation for the heart failure. And you diagnose it by doing an ECG. You will find normal P waves and normal QRSs, and the ratio between them is 1-to-1. Okay, so it's easy to diagnose sinus tachycardia by the ECG. And once you do that, you have to look for the cause of the sinus tachycardia. Very rarely there are, other diagnoses other than the sinus tachycardia, meaning, the differential diagnosis that I put up here. So you don't have to remember this last point. But only if you diagnose a patient with sinus tachycardia, you have to look for other causes. And we have multiple causes in children. So to name a few, you can have a child who's in pain, for example, or if he's dehydrated, or if he has a fever or sepsis. If he's in shock, you will have sinus tachycardia. So always look for the other causes that will result in this. If you're giving nebulizers with Ventolin or beta agonist, the child will have sinus tachycardia. If somebody is drawing blood on the child and he's tachycardic, obviously that might be the cause of the sinus tachycardia, etc. Hyperthyroidism, anemia, etc. Okay. So the second cause of tachycardia, other than the sinus tachycardia, is the ventricular tachycardia. Not the second cause as in frequency of the causes, but the second cause that I will talk about, because it's really easy to recognize, is ventricular tachycardia. So VTAC is always wide complex. So to pick a patient that he has a VTAC, you only need to do the ECG. If it's wide, just consider it as ventricular tachycardia until you rule it otherwise. Okay? So all VTs are wide. Okay? The rate in children is not a fixed number because a neonate is different from a 3-year-old. So the rate in children is just you need a higher rate, more than 20% of the expected sinus rate. So if a child is resting and there is wide complex ECG, but his ECG is at a 130 and the child is 1 year old, this may not be ventricular tachycardia because it's really close to the sinus physiologic rate. So it might be it's wide because of something else, not because of VTAC. But if it's 180, then it's really higher than what you expect at this physiologic state. So you call it ventricular tachycardia. So just make sure that you apply the two things, ventricular, which is wide, and tachycardia, which is rapid heartbeat. Okay? Not every wide complex is tachycardia. Sometimes it's only a normal rhythm for the child and he has bundle branch block. Bundle branch block will give you wide complex, but if the rate is normal, then it's probably that's his rate, not ventricular tachycardia. So this is the limit that we take. If it's higher than 20% of the expected sinus rhythm, we call it ventricular tachycardia. In adults, it's 130, I think, the cutoff. Anything above 130, they call it VTAC. Below 130, they call it ventricular rhythm, not tachycardia necessarily. Okay. There are things in the ECG that may lead you to say this is definitely ventricular tachycardia, such as sinus capture beats, so occasional sinus beats within the tachycardia itself. Or dissociation between the P waves and the QRS. This is an example of ventricular tachycardia in children. So you know that the QRS is very wide and the rate is very fast. So this rate is much faster than what you expect for sinus node. Then this is ventricular tachycardia until you rule it otherwise. So what do you do when you have ventricular tachycardia? You go to the VTAC rhythm. We'll just talk about it in a little bit. Okay? So now we talk about supraventricular tachycardia, which is the most common diagnosis of abnormal arrhythmias in children. So VTAC is much less common than SVT in children. So supraventricular tachycardia is not always narrow. It's usually narrow complex, but it's not always narrow. So that sometimes makes it a little confusing. If you have a wide complex, it could still be SVT, not VT. But for the sake of management, consider VT until you rule it otherwise. So it's usually narrow, but not always. And the rate is usually outside the limits of the sinus node. So if I'm a 10-year-old, my sinus node can go up to 210, which is 220 minus my age, as the maximum. So no matter how much I have tachycardia, it should not go beyond 210. A neonate should not go beyond 220. If it's over this number, then it's probably not the sinus node. The sinus node will not be able to do this. Okay? The presentation is very variable, and that's what makes it difficult, because if a neonate has SVT, he will not complain. He might present with heart failure, for example, if the SVT is persistent. An infant is also likely to present with heart failure or poor feeding or pallor or sweating. Older children with SVT can present with palpitation or dizziness. Fetuses with SVT might present with hydrops, for example, hydrops fetalis, because of heart failure. Okay? When we say the word SVT, it doesn't mean that it's a single diagnosis. It's just a phenomenon. And there are many causes of SVT for to know, according to the mechanism of the SVT. So some of the causes are listed here. Those are the most common causes, which are the AVRT, which is atrioventricular reentry tachycardia. So you mean there is a circuit within the heart that results in fast heart rate. There is atrial tachycardia, which is one cause of SVT that is because of automatic focus in the atrium that just gives you higher rate than the sinus rate. Another cause is atrioventricular nodal reentry tachycardia. You will hear this term also sometimes, and this is also a circuit. Anytime you hear the word R, reentry, it means there is a circuit in the heart. Okay? But there are multiple other causes. You have atrial fibrillation, atrial flutter, you have junctional ectopic tachycardia, etc. So many causes of SVTs that you might encounter, but those are the three more common ones. The most common, obviously, is atrioventricular reentry tachycardia. So in order to diagnose these, you need ECG, and you need also the condition of the child, the clinical picture of the child. So let's talk first about the ECG approach. So you have a child who's complaining of palpitation, or a child in the ICU, and the nurse is telling you his heart rate is very fast. You will get a 12-lead ECG and then go step by step according to this suggested algorithm. So first of all, we establish that he has tachycardia. This is abnormal tachycardia. So you need to diagnose this tachycardia. First, look at the ECG, look at the QRS. If the QRS is wide, then what is it? You go along the path of ventricular tachycardia. If it's narrow QRS, then it's definitely not ventricular tachycardia. Okay? So if it's wide, try to verify, is it really VTAC, or do I have any evidence that it's not VTAC? So if it's VTAC, then you go down the algorithm of VTAC. If it's not, then, so it's VTAC, for example, if there is sinus capture beats, or the P waves are much slower than the QRSs, then this is definitely VTAC, and you go to the VT algorithm. VT algorithm you probably remember from your advanced life support course. If you have VT, check the pulse. If it's pulseless, treat it as VFib, which is by DC shock. If there is VT with pulse, then you can try synchronized cardioversion and medications, etc. Okay, so that's VT. We will not talk a lot about VT. If it's wide complex, but there is evidence of one-to-one conduction, then it could be SVT with bundle branch block, for example. So because bundle branch block will give you wide QRS complex, and SVT will give you the tachycardia. So the tachycardia will be wide complex. So we call it SVT with aberrant conduction. Okay. And if you're in doubt, you treat it as VT, but if you're sure that this is SVT with aberrant conduction, you treat it as SVT. Yeah. أقل من 1 لوان. يعني the P wave rate is going at 100 and the VT is going at 180. Yeah. Right. You don't see the P waves in the monitor, but if you do a 12 lead, you might be able to detect some of the P waves. And if you see them at different places across the QRS complex, then you might say, well, this is more likely the P wave, and it's just going at its own rate. So always do a 12-lead ECG if you have time. If the monitor tells you this is wide complex and the patient is crashing, you might go and just do the shock. But if the patient is stable and talking to you and he's just uncomfortable with the palpitation, then you have time to do a 12 lead, and that 12 lead can be of good guidance to you. Okay. So if the QRS is narrow, as we said, fast rhythm, QRS is narrow, this is definitely supraventricular tachycardia. There are a few things that you can look at the 12 lead ECG to help you. So look for the P waves. Where can you find the P wave on the ECG of SVT? It can be present, you can see it. If it's more than 1-to-1 conduction, you have abundance of the P waves, much more than the QRSs. This is atrial flutter. So if you have like a sawtooth appearance, the baseline, so the P waves are abundant, and the QRSs are half of that or 1/3 of that, this is mostly atrial flutter. So why is it important to know that this is probably flutter versus non-flutter SVT? Because the treatment is different. If you have flutter, it will not respond to adenosine, and it will need cardioversion. If there is 1-to-1 conduction, so you are able to see the P wave somewhere, and there is equal rate of the P wave and the QRS, then you can also look where is the P wave in relative to the QRS. So you can divide the SVTs into short RP and long RP SVTs. So the easy way to look at is short RP means the P wave is closer to the preceding QRS. Long RP, the P wave is closer to the following QRS. So determine where is the P between the two QRSs. If it's closer to the one behind it, then it's called short RP. And most SVTs are short RPs. You can find it close to the next QRS, just like this one, which is more likely similar to the sinus tachycardia, but it's really very fast, faster than the sinus tachycardia. We call this long RP tachycardia. So as we said, which one is more common? Short RP tachycardias are more common because most SVTs, the P wave will be a retrograde P wave from the ventricle. So it will be very close to the preceding QRS. And there are examples of this. So most Wolff-Parkinson-White SVTs are short RPs, different from short PR. Short PR in the sinus rhythm, but short RP during the SVT. During the SVT, it will be short RP. So the pathways will result in short RP tachycardias. Also the typical AV nodal re-entry tachycardia, which are the two most common causes of SVTs. So most likely you will get a short RP tachycardia in most SVTs. Long RP tachycardia, why is it important to know this is long RP? Because adenosine will not work in most of them, and DC shock will not work in most of them. Okay? So you might need just medications. So one major example is atrial ectopic tachycardia. You will get a long RP tachycardia. Don't try adenosine and don't try DC shock. Just give some medications, beta blockers, and other antiarrhythmics. It might help you. So sometimes we say SVTs, you don't have P waves, but you do have P waves. Sometimes they are difficult to see. So if you look carefully, you might see the P waves. So where do we look? We look like those examples. You can look just after the QRS. You might see it before the T wave, or on the upslope of the T wave, or the tip of the T wave. You might see an indentation. That might be the P wave. So then you go with the algorithm. Is it long RP or short RP? Okay, in terms of mechanisms, how can we understand the SVTs in terms of mechanism? As we said, we have two mechanisms of SVT, either a re-entry mechanism or an automatic mechanism. Okay, so those are the two mechanisms for the supraventricular tachycardia, despite the long list of causes, but those are the two mechanisms. So you either have a re-entry circuit or you have an automatic focus. Automatic focus will be taking over from the sinus node because it's faster from the sinus node. But the re-entry, it will not take over from the sinus node. It's just a re-entry circuit, so the sinus node will be sitting down, sitting not doing anything because it's overdriven. There is something faster than it. The circuit is very fast. So the non-re-entry tachycardia, when you hear the word ectopic, that's basically non-re-entry. So ectopic focus is just a focus in the heart that's faster than the sinus node. This is a focus. So that's why if you diagnose this like atrial ectopic tachycardia or junctional ectopic tachycardia or multifocal ectopic tachycardia, that means there is an extra focus in the heart. So giving adenosine will not help because it works on the AV node. So once the adenosine is gone, the ectopic focus is still going. And also doing a DC shock will not help because DC shock will depolarize everything, and then the faster focus will rise up again. So which one is the faster focus? It's the ectopic focus. So also DC shock will not work in the ectopic foci. Okay? So don't try it. Or if you try it once and it didn't work, just stop trying it because it will cause harm to the heart. Okay? But in re-entry tachycardia, when you do the DC shock, so you depolarize everything, so every part of the circuit will be depolarized, and then the fastest focus will rise again, which is the sinus node. There's no focus in the re-entry circuit, so that it will respond to the DC shock. So that's why if you know it's automatic, don't give DC shock and don't give adenosine. But if it's re-entry, you can further divide them into accessory pathway re-entry or non-accessory pathway re-entry. Okay? The accessory pathway re-entry examples of those are Wolff-Parkinson-White, and similar to Wolff-Parkinson-White, any accessory pathway, we call it concealed Wolff-Parkinson-White or hidden Wolff-Parkinson-White. So basically, if you have a pathway, you call it Wolff-Parkinson-White, and there are others, not important to know them. The non-accessory pathway tachycardias, we have atrial flutter and fibrillation. Those are the re-entry tachycardias. So those are not automatic tachycardias. The atrial flutter and fibrillation, those are re-entry, but re-entry circuit is within the atrium. And you have the AV nodal re-entry tachycardia, and we have others after cardiac surgery. So those are the three important things to remember: AV nodal re-entry, flutter, or fibrillation. So knowing the mechanism will help you treat the patient. So in summary, as we said, this side of the slide, it's automatic. So only the treatment is medications until you do the ablation, the ultimate management, which is to burn the ectopic focus. Okay? So DC shock will not work, adenosine will not work. Vagal maneuvers might slow it down temporarily, but it will come back. Okay? This side of the slide, the re-entry, all re-entry can be managed with cardioversion, electrical activity. They will respond. They might come back, but they will respond. Okay? This side of the slide will not respond to adenosine. Okay? Why? Because adenosine works on the AV node, so it will work if the AV node is involved in the tachycardia. Sorry, I said something wrong. So it will work with this side of the slide and with the AV nodal re-entry tachycardia because it's involving the AV node. But adenosine will not work in the atrial flutter, and it will not work with the atrial fibrillation because it blocks the AV node for a few seconds and then it's gone, so the tachycardia will continue. Important to understand the Wolff-Parkinson-White mechanism. So this is a heart with an accessory pathway. So as we said, the impulse will come from the sinus node to the AV node. The AV node will delay it and then will conduct it very fast to the ventricles through the Purkinje system. So usually you will get a P wave and then PR interval, which is an interval of the delay of the sinus AV node. And then you will get a narrow complex QRS because the conduction is fast through the Purkinje system. If you have accessory pathways don't have delays, so they conduct right away, so you get a short PR. So the P wave, and then you will have a delta wave. Right after the P wave, the conduction to the ventricle starts, and that will result in wide complex QRS. So the red is the patient with Wolff-Parkinson-White, the blue is the normal. Okay? So you'll get wide complex QRS, you'll get short PR interval, and the delta wave. Okay. So what happens in tachycardia? You will get a circuit. So because you have two pathways to the ventricle, then it potentially can give you a circuit. Okay. The conduction will go down the AV node and then up the accessory pathway, which is the most common type of Wolff-Parkinson-White. We call it orthodromic tachycardia. Orthodromic means it's going down through the AV node and then up through the accessory pathway. So that will give you a short PR, short RP tachycardia. So down through the AV node there is a delay, and then up through the accessory pathway without a delay. So you'll get a negative P wave just after the QRS. So a 14-year-old presents with episodes of palpitation and everything else is fine in the history. You examine the child, he's fine. And then you get an ECG and you find this ECG. This is diagnostic of, it's Wolff-Parkinson-White. Okay? So you see the P wave and the R wave very short. So the PR interval is very short. And you see that the QRS is not very narrow, so it's wider QRS. And if you look in some views, you can see the delta wave, not in every one, but maybe in V4. You see the upslope of the QRS. It's going up smoothly without any Q wave. So this is Wolff-Parkinson-White diagnostic of his SVT. AV nodal re-entry tachycardia is also a circuit, but the whole circuit is within the AV node. So you will get two pathways within the AV node, and that will result in an impulse going down one pathway and up the other pathway. So we call it atrioventricular nodal re-entry tachycardia. So in this patient, and when he's not in tachycardia, his ECG is perfectly normal. There is no delta wave. But when he's in tachycardia, you will get a short RP tachycardia in most of these patients. So that's not important. The details are not important. Just know the name, atrioventricular re-entry tachycardia. It means the re-entry circuit is within the AV node. And this is an example of atrial ectopic tachycardia in a baby. So this patient had rapid heart rhythm, and then suddenly it actually went away spontaneously without any intervention. And you note that the P wave was small and then it got bigger. So this was the normal sinus rhythm, and this was an abnormal P wave. So it's an ectopic focus coming from somewhere else. And it was faster, and then it just died off. It wanted to rest. So the sinus node will come back. Okay? And this is, as we said, a long RP tachycardia. The R to P is longer than P to R. Okay. So if you get a patient with SVT, now we have to manage this patient in the emergency room. Okay. Management starts first with assessing the clinical picture. So if the patient is unstable, so the patient does have SVT on the monitor, his heart rate is 250, but the patient is unstable. He's not conscious, there's low blood pressure, no perfusion. So you have to do the fastest therapy that you can give. So the fastest therapy involves no IV lines, no cannula insertion, etc. So the fastest is the electrical synchronized cardioversion. Okay? So just hook the machine, put gel, and do the synchronized cardioversion. But thankfully, most SVTs are stable. So when you get a patient with SVT to the emergency room, most of them are conscious. They're not unconscious, and most of them will have some weak pulses. They can talk to you, etc. So what do you do? So if the patient is stable, obtain the 12-lead ECG. Don't rush and do the vagal maneuvers, because you need documentation of your SVT, and you need to look at the ECG to try to figure out the algorithm that we said. Is it long RP? Is it short RP? Is it flutter or fibrillation, etc.? So do the ECG, and then based on the ECG, the suspected mechanism, you do the management. So if you think it's a re-entry tachycardia involving the AV node, by looking at the ECG, there is short RP tachycardia, for example, there is suspicious history of Wolff-Parkinson-White in the past, etc., then you do adenosine. It's very effective to block the SVT. If you think it's a re-entry, but it's not involving the AV node, for example, you see flutter waves on the ECG, there is a sawtooth appearance, then don't give adenosine. You might try it for diagnostic purposes, but it will not break the tachycardia. Then you do the synchronized elective cardioversion. Patient is stable, so just sedate him, do the echo to make sure there is no thrombi, and then do the elective cardioversion. If it's automatic tachycardia, you see there is a P wave before every QRS, and it's abnormal P wave coming from the left atrium, for example. So this is atrial ectopic tachycardia. As we said, this will not respond to either adenosine or the elective cardioversion. So what you do medical cardioversion. So give a bolus of medication, beta blockers or amiodarone or procainamide, etc. And then the ultimate therapy based on the diagnosis will be either ablation or radiofrequency ablation or sometimes surgical procedures. This is an example of a common SVT that comes into the emergency room. Maybe an adolescent coming into the emergency room, feeling of palpitation, he's pale. You do the ECG, the monitor will show you the heart rate of 250, for example. You do the ECG and you find this. Narrow complex, so it's definitely not ventricular tachycardia. Rate is 230, this is definitely not sinus tachycardia. Then you go along and try to find where the P waves are. And in this ECG, you might see a P wave just here at the ST segments, just a negative notch in the ST segment. So this is a short RP tachycardia. So adenosine will likely work in this patient. While in this patient, you see a patient coming in with palpitation, the monitor will tell you that this is irregular rhythm. So you do the ECG and see, so it is indeed a regular rhythm, but it's very fast. So the QRS to QRS is not fixed duration, and you don't see a clear P wave. So fast rhythm, irregularly irregular, is called atrial fibrillation. So adenosine will not help. You need to do a synchronized cardioversion. That's it. Any questions?